Good morning, afternoon, and evening to everyone joining us from different corners of the world. I am Viviana Munoz-Teles. I head the program at the South Center on Health Issues, and I'm very pleased to be opening this webinar. The South Center is an intergovernmental organization of developing countries that works on policy-oriented research and provides technical assistance and capacity building on various development issues, including public health. Responding to the global challenge of rising antimicrobial resistance, of drug-resistant infections, is an important part of our work in the area of public health. You can also visit our website where we have numerous publications and more information of our activities. This webinar is organized today to mark the start of the World Antimicrobial Awareness Week 2024. The webinar will highlight essential strategies and success stories in AMR surveillance and stewardship in the Global South. The webinar will have two sessions that aim to provide practical insights and evidence-based recommendations for strengthening antimicrobial surveillance and stewardship policies and clinical practices, particularly in resource-limited settings. After a first learning session on enhancing AMR surveillance, in a second session, a panel will discuss experiences for how to implement antimicrobial stewardship and surveillance in developing countries. We will start with a learning session on the topic of enhancing antimicrobial resistance surveillance in developing countries. And to deliver this, I am very pleased to introduce my colleague, Dr. Rasha Adel-Salaman El-Shenawi. Dr. El-Shenawi is a distinguished Egyptian clinical pharmacist with over 20 years in pharmacy practice, and she is also director of the Antimicrobial Stewardship School at FADIC in the United Kingdom and a consultant with the South Center. She is also a senior lecturer and supervisor at the University of Hertfordshire in the United Kingdom. Rasha, I pass on to you. Thank you.
Good afternoon, everyone. Good morning for any other when listening from other places. Nice to meet you all. And I'm delighted to be with you today to share my presentation about the surveillance in the developing countries and what are the challenges of the surveillance or what is the data gap and how to overcome these challenges. My name is Dr. Rasha Abdel-Salam, and thank you very much for introducing me. I will start my presentation today. I have the conflict of interest regarding this presentation, and I will start this presentation today with the learning objectives. The first one is to identify the primary challenges in antimicrobial stewardship surveillance in the developing countries, exploring the strategies for improving antimicrobial resistance, data collection and reporting, emphasize the importance of regional and global collaboration in antimicrobial resistance, examine the role of digital tools as part of enhancing anti-AMR surveillance, and provide resources to support effective antimicrobial stewardship practices and improve surveillance in the limited resource countries. I will start with my presentation today with the key concept. The key concept I will start my presentation with this quote from Lord Kevin about if you cannot measure it, you cannot improve it. What I mean from this quote, if we cannot or if we can measure something such as antimicrobial resistance and express it into numbers, we truly be able to understand it, to provide better understanding, to discuss it, to effectively fight AMR. I will begin with this photo of the blood culture of the patient, which is resistant to all available antibiotics. This patient has multi-drug resistant bacteria. And this is a problem of antimicrobial resistance because antimicrobial resistance become now a global challenge. Recently, the latest Lancet study published last September with the results that the antimicrobial resistance could cause 39 million deaths between 2025 and 2050. For this reason, urgent action should be required to maintain effective antimicrobial stewardship, such as recommended by the WHO, and to promote the AMR surveillance. For tracking the antimicrobial resistance in the developing countries, we have some important issues need to be considered. Comprehensive antimicrobial resistance surveillance data is lacking. Developing countries have a high health and economic burden for MR. Data is fragmented and lack representative for the current situation. It really required step-by-step improvement to improve the strategies for antimicrobial stewardship and AMR surveillance. There is absence of reliable data that could be representative for the AMR surveillance in the limited resource countries, and the poor data quality. All of these factors are among many factors that make track gap or data gapping in the developing country surveillance. I will summarize them into four key challenges for AMR surveillance, which represent number one, technical challenges, lack of the infrastructure and inconsistent method of AMR surveillance among facilities. The second one is financial constraint or lack of the workforce and insufficient funding programs that couldn't support AMR surveillance. The third one is infrastructure limitation, lack of digital system and infrastructure, poor network and poor communication and connectivity in the rural area. And data quality, the absence of standardized data regarding the AMR surveillance, one of the biggest challenges to promote the AMR visual representation and surveillance. When we try to speak about the solutions or the four effective strategies for AMR surveillance, it includes building a capacity for clinical practice, like investing in the training programs, in practices, in surveillance protocols for antimicrobial stewardship, promote stewardship team and resources that could facilitate AMR surveillance. The second one is resource allocation. By optimizing the resource allocation, by maintaining a high priority or prioritize the high burden hospitals for initial surveillance will maximize the impact in the limited resources. Additionally, when prioritizing the high risk area for antimicrobial stewardship practices and implementation will make like a role model for other facilities and other healthcare settings. The third strategy is to implement a standardized protocol, such we find in WHO recommended guideline. We can adopt this guideline and this protocol with regard to the healthcare facility to ensure consistency in data submission. And finally, focus in sustainability or sustainable antimicrobial stewardship practices with regard to the funding model. By advocate and invest audit way and promote audit protocol to maintain sustainability in antimicrobial stewardship practice will help to promote evidence-based or promote effective MR surveillance. After COVID pandemic and after the dilemma of the COVID-19 and now the digital and technology have an important role in MR surveillance. The advantage of this digital tool is very, very impressive because it improves accuracy of data collection and aggregation. It provides like a streamlined process to reduce the reliance on manual and error-proof data entry, provide like real-time data sharing that help in monitoring or frequent monitoring of AMR trend. And this is important and very, very important when comparing to the other traditional or manual methods, because the mobile application for healthcare worker in remote area will help to collect and transmit the data easily and provide storage of the data, analyzing data, and promote one of the most important issue, which is predictive analysis. We could be able to predict, identify any outbreak or any emergency or crisis that could help to take the further or the required action prior pandemic or prior any emergency in the future. For this reason, each country is important to have national AMR surveillance or action plan that promote national AMR data surveillance in order to be able to identify the trend, the resistant pattern for any specific pathogen, for any antimicrobial susceptibility, provide a monitoring way to monitor any healthcare associated infections or community acquired infection, to be able to track these infections and take the corrective action for all of these infections to help to decrease the number of AMR resistance. This will strengthen the diagnostic capabilities because it will ensure or enable precise treatment decision, optimize the antibiotic prescribing, the presence of the protocol, the presence of the guidelines will help to promote effective antimicrobial stewardship. We need data. When we understand the data, when we able to visualize the data, see the resistant pattern, in the local facility and in the on the national level will help the prescriber, doctors and the pharmacists who dispense and the nurses and all workforce to take the precise and correct treatment action, which is the meaning of the antibiotic stewardship, is to be able to maintain the right use of the antibiotics. So the presence of this data will help to enable or support the precise treatment decision and the effective antibiotic stewardship practices. Additionally, help in preparing for any public health emergency and provide corrective response regarding any crisis and maintain the surveillance reliability. We could depend on this data to take the correct action and maintain the right use of the antibiotics. Here are the examples from the regional collaboration, such as South-centered World Health, WHO, and the United Nations. And I like in this presentation to stress on important AMR surveillance dashboard from the WHO, which is called the GLOS. It's very brilliant source. I put the reference by the end of my presentation if you need to go, because it provides like a surveillance or a global surveillance for pathogen specific data. We can track among different countries and also the antibiotic consumption among different countries, such as meropenem, ciprofloxacin, and other antibiotics. This will help to benchmark or provide an overview or global picture for each country that could help to build on the future decisions for any countries. The AMR surveillance from the WHO contain two important categories: the antimicrobial resistance, which is AMR trends, and the antibiotic use or antibiotic utilization. This is or antibiotic consumption to help to understand the pathogen or the bacteria and the antibiotic and what the presence of the drug resistant bacteria and follow up any trend or pattern. It's really important. I highly recommend it for all of you to see this. I put all of the reference by the end of the presentation because it provides an important interactive dashboard. It's really impressive. And I put some snapshots from the GLASS report in 2022, which including many surveillance data about the pathogens and what is the trend of the pathogen and the infections. Starting, for example, this bloodstream infection from 2016 to 2020, and what is the most common countries that has this infection, the urinary tract infection. I don't have time to go for all the report, but it's highly recommended to go and read this report. It provides a dashboard also interactive for any country. Here is also an example for the third generation cephalosporin, the E. coli resistant and MRSA or methicillin resistant Staph aureus, and how the number is increased among different years. I put many examples from the GLASS report. I highly recommend to go through this report and read it. And it also provide an interactive dashboard. You can select the country and see all or visualize the data from this country. I put the link here and also by the end of my presentation in case you're going to go and read it in more details. So I was also delighted to introduce the South Center of the 55 countries and explore how the GLASS report or the WHO AMR surveillance in these countries. For the 55 countries of the South Center, we see here with regard to the AMR or antimicrobial resistance, the pattern from 2016 until 2021, and also for the antimicrobial use or consumption, the pattern among the 55 countries from 2016 to 2023. Here is the graph for AMR surveillance in South Center countries. We see here in 2016, 2017, 2018, the numbers is increasing, and the total number of countries, 33 countries enrolled in the AMR surveillance. Before the pandemic, the time from 2019 until 2016, there was 27 countries. We hopefully plan to increase these countries enrollment of these countries in AMR surveillance of the WHO. That would be very helpful to visualize the trend and pattern in antimicrobial resistance. And here is the AMR or AMU or antimicrobial use among the countries of the South Center when we see that 2020 is highest and then 2022 with overall countries is 21 enrolled in the antimicrobial use surveillance. I found in the literature another is interesting study, but the time is running. I highly recommend it to read this study based on 2021 study published. This comparing 6 countries, Bangladesh, Brazil, India, Lebanon, and Malaysia, and South Africa from enrolled in the GLASS AMR. It's very, very interesting to read. I put this paper in order to know, to be able to compare. This data is valuable to provide like a benchmark on the country level and on global and national level. Finally, I will end up with my presentation with some recommended sources and toolkits for antimicrobial stewardship, including courses, toolkit, resources, and journal articles. The courses are a lot of courses in the literature, but I try to select the free courses, which is accessible for anyone to go and enroll in these courses, starting from the WHO open courses, the British Society of Antimicrobial Chemotherapy open course for antimicrobial stewardship, the Future Learn and Coursera, this course from University of Dundee, University of Stanford, and European Society of Microbiology promote antimicrobial stewardship certification, and the European CDC promote training courses for antimicrobial stewardship and e-learning modules, and also the US CDC. There's a lot, many resources, but I try to get like a snapshots from the most common courses. Secondly, the toolkit. I go with the WHO aware classification for the WHO classified the antibiotic to access, to watch, to reserve. So it is important to go and see this list of classification from the WHO and this GLASS report when we, as we discussed in earlier slides. And also the Infectious Disease Society of America promote important guidelines for antimicrobial stewardship implementation. Public Health Ontario in Canada provide an effective, very comprehensive resource of antimicrobial stewardship. And the United Kingdom, the UKHSA, provide the surveillance report, SPOR report, and also the toolkit for antimicrobial stewardship, which is called Start Smart Then Focus. We use this tool here in the UK, and I highly recommend to implement this tool. It's really impressive in either in the low income or high income. This is like a roadmap for antimicrobial stewardship practice and implementation, starting from Start Smart for the initial course, then assess all of these criteria and review the antibiotic after 48 hours before prescribing the second course of antibiotic, which is then focus criteria. I put the link for all of these resources by the end of my presentation. For the third resource, which is the antibiotic stewardship resources, I put the WHO, I highly recommend to read, and also the African CDC, the UKHSA Antibiotic Guardian promote very helpful resources with regard to the UKHSA, and the CDC has an important toolkit and the important source for antimicrobial stewardship. And I highly nominate the United Nations previous assembly, which include rich source of information about antimicrobial resistance and the importance of antibiotic stewardship. Finally, the journal articles. I put some journal articles. I'm honored and delighted to write these manuscripts or these articles, which published in Frontier to compare the WHO aware criteria. And also this paper from in Public Health Journal, this like a roadmap or the including all about antibiotic stewardship from the 20 years from the literature. It's like a reference for anyone who wanted to depend on it for establishing antimicrobial stewardship. And the third one is the impact of the COVID on antibiotic stewardship. And there is also paper for using the novel strategies in antibiotic stewardship. And finally, the use of the 5 rights of antibiotic safety to maintain the right use of antibiotic in the Global Journal of Antimicrobial Resistance. To end up my presentation, I want to end up with key barriers for facilitating data or AMR surveillance, including the weak laboratory infrastructure, insufficient workforce, inconsistent funding, data gap, and the poor standardization, the quality of the data, and finally, the collaboration and the communication. The key takeaway from my study or from my presentation, including 5 important elements. The healthcare accessibility. There is limited access for healthcare service in many regions that affecting this surveillance. The second one is workforce limitation, the shortage of skilled healthcare professional affecting the effective AMR surveillance. The third one is systematic barrier. There is barrier for the system. Addressing these challenges is crucial to improve or ensure the effective AMR surveillance. The urban local areas and the difference in monitoring of healthcare acquired infection, for example, in ICU or intensive care units or emergency departments versus the community acquired infections, and the healthcare challenges for the defect or inadequate infection prevention and the control and limited access to clean water and sanitation. To conclude my presentation, the presence of effective strategy in AMR surveillance is very important to maintain and visualize the data, trends, be able to take the corrective action to confront or fight the antimicrobial resistance. Addressing this challenge is very important. Using the technology, using the digital solution is very important to empower the AMR surveillance and enhancing the healthcare system to build a resilient system and a flexible system for effective surveillance, effective antimicrobial stewardship practices, and improve the global health outcome. This is the end of my presentation. I put the resources with carefully in order to be like a comprehensive resources for the courses, for the toolkit, for the resources, for the journal papers. And I'm delighted to be with you today. And thank you very much for listening. I'm not sure if anyone have any question or we go to the second part of the panel discussion.
I think, Rasha, will need to move to the second part and see if we can take some questions at the end.
Okay. The second part of our webinar today is an important panel discussion, and I'm delighted to be the moderator for this panel discussion about success stories and MR data in implementing effective antimicrobial stewardship and surveillance in developing countries. And I'm delighted to have 3 important speakers with us today. Dr. Kamini Walia. Dr. Kamini is Senior Scientist at Division of Epidemiology and Communicable Disease, Indian Council of Medical Research, in New Delhi. Dr. Kamini is currently leading antimicrobial resistant initiatives and focusing on antimicrobial resistance, including surveillance, antibiotic stewardship, and One Health approach. She received her PhD from Postgraduate Institute of Medical Education and Research and did her master in public health from Johns Hopkins. During her 20 years of experience in public health, she initiated successfully numerous projects on public health. And I'm delighted to have her with us today. She has a good opportunity, and she is a former member of WHO Scientific Advisory Group of Experts on Essential Diagnosis. Thank you very much for joining us, Dr. Kamini, today. Dr. Sashila will be the second panel with us. Dr. Sashila, a consultant infectious disease physician and the professor of medicine at University of Malaya in Malaysia. She is a head of infection control department and the chair of antimicrobial stewardship committee. She has a deep commitment to antimicrobial resistance and advancing patient safety. Her leadership, including 2022 Asia Pacific Hand Hygiene Excellence and Action Plan for Antimicrobial Resistance. She contributed in developing guideline, education, training of antimicrobial stewardship and infection prevention. Her primary research interest focusing on hospital-acquired infection, antimicrobial resistance, and has a great impact on public awareness with her expertise to inspire action in fighting antimicrobial resistance. Thank you, Dr. Sashiri, for joining us today. And finally, we have Dr. Afrinich. Dr. Afrinich has experience of national and international level in antimicrobial resistance surveillance advocacy and stewardship and laboratory system. Her work focuses on pathogen genomic surveillance, cholera control strategies, and the AMR action package and bacterial management. She has 85 publications in national and international conferences. She is a member of Technical and Global Health Security and a fellow of biosafety and biosecurity, consultant of antimicrobial stewardship, visiting faculty at medical university and health service academic in Pakistan. Thank you very much all for joining us today, and I'm delighted to be with you today in our panel discussion. We have nine questions, and I would be delighted if you could join us and answering our questions. Are you ready to start?
Yeah, definitely. Looking forward to it. And thank you for the invite.
Thank you very much. I will start with Dr. Sashila, can you explain the role of antimicrobial stewardship in confronting or combating the antimicrobial resistance?
Yeah, thanks, Rasha. So as we all know, I think everyone here knows that antimicrobial stewardship is a critical strategy in reducing antimicrobial resistance as well as preventing hospital-acquired infections due to AMR. So as you all know, ASP is actually a coordinated intervention designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of the optimal antibiotic drug regimen, including dosing, duration of therapy, route of administration. And the key objectives and, these interventions have shown to actually enhance patient safety by decreasing morbidity and mortality, decreasing adverse effects due to inappropriate antibiotic use, decreasing length of hospital stay, as well as, even drug-drug interaction. And one of the other objectives is to curb inappropriate antibiotic use, especially, in tropical countries like ours, where we have lots of dengue. We have patients even getting antibiotics due to non-bacterial causes. The other important strategy in AMS, as you know, the WHO has come up with the AWARE classification, and is to promote the use of excess antibiotics instead of the watch and reserve antibiotics as much as possible for infectious syndrome. And the other benefit, of course, is economic benefit, both to the patient as well as healthcare system. So it really highlights the importance of EMS in combating AMR in multi-factors. But I also, as we all know, I also like to highlight that many research as well as systematic reviews have shown that EMS is most effective when it's integrated with infection prevention and control. And I think this is a very important fact for us to know in developing countries, because if we were just to go and work on antimicrobial stewardship and don't improve infection prevention, then it will be a catastrophic failure, because the main aim is for us to reduce infection so people will not take antibiotics or fall sick in the first place. So
yeah, thank you very much for answering our question. We have the second question, Dr. Kamini. What are common barriers to antimicrobial stewardship in your experience, and how have you worked around them?
Thank you. Thanks for initiating this very interesting discussion during this very important week when we create awareness about antimicrobials. So my experience on antimicrobial stewardship comes from India. And like India, many resource limited countries do not have funds allocated for activity like antimicrobial stewardship in our hospitals. So this is one of the first barriers, that we need trained human resources, we need good quality labs, we need focus on infection prevention and control, as Sashila highlighted and you also highlighted in your talk. But there are no resources. The training of nurses on infection control practices, that all this is actually not something which the health administrators or the hospital administrators invest on. So this is one of the biggest challenges to apprise the hospital administrators that they would need to invest on infection control processes, on creating resources for practice of antimicrobial stewardship. As Sashila very rightly pointed out, that we cannot practice antimicrobial stewardship in absence of good infection control practices. Most of the time, what we see is that the antimicrobial prescriptions actually are trying to compensate for compromised infection control practices in the hospitals, or absence of diagnosis, which is not there because of the good quality labs. Whenever clinicians will doubt infection control processes or a lab report, they will not de-escalate, and they will not reduce the antimicrobial prescriptions, because no physician wants to lose a patient. The second most important barrier is that we do not have clinicians taking interest in making AMS as part of their the list of priorities. In India, what we faced was that most of the AMS was being pushed in hospitals by microbiologists, and most of the administrators would not really give it as much importance. So making clinicians as a face of antimicrobial stewardship programs in the hospitals actually helped us a lot, and in prioritizing AMS activities within the hospitals. Also important is the trained human resources. The most of our understanding on antimicrobial stewardship and how they should be implemented in the hospital comes from the West. They have ID physicians, they have clinical pharmacists. Unfortunately, in India, we do not have that many ID physicians who are trained in infectious diseases, especially our government hospitals do not have ID physicians. So in absence of ID physicians, who will lead the AMS? So what we found was that any clinician who is passionate about antimicrobial resistance, who is passionate about AMS, whether he's a pediatrician, whether he's a intensivist, or whether they are medicine physicians, they could lead these antimicrobial stewardship program in these hospitals. So these were some of the solutions that we found locally, so that we can improve the practice of AMS in the tertiary hospitals in the country.
Thank you very much for your comprehensive answer. It's really important. Could you share an example of successful antimicrobial stewardship program and what made it effective, Dr. Kamini?
Yeah. So this I will lead from the points that I made in my previous response. So we have a network of 20 hospitals in our network. They are all tertiary care hospitals and one of the leading hospitals in the country. So making clinicians lead these projects, which we initiated in these hospitals, was actually the key to success. Also, most of these hospitals did not have clinical pharmacists. So, as a part of the project funding, we provided a position of a clinical pharmacist to all these hospitals. And it was really nice to see that on the completion of the project, two of the hospitals actually created a post of a permanent clinical pharmacist for antimicrobial resistance in their hospitals. So, this I would say was one of the key successes of this strategy. What we can say is that unless we provide the extra resources to initiate antimicrobial stewardship and to continue and sustain these activities, even if we manage to initiate them, we will not be able to sustain them unless they are supported by extra resources. So having resources, having clinicians as the face of the AMS program, having trained workforce, whether they are infection control nurses, good quality clinical pharmacists, good quality laboratories, all these are actually the pillars of antimicrobial stewardship in any hospital. And also important, as you very rightly mentioned, is the guidance documents. In India, we have a antimicrobial stewardship policy which was brought out by Indian Council of Medical Research. It is a guidance document any hospital can use to implement AMS program in their hospitals. So these are the various factors which we tried to strengthen as we initiated this program in 2017, and now almost 7 years into this particular initiative. These are some of the interventions that has helped us sustain these initiative in these hospitals. And also we have seen incremental progress in terms of the interventions like prospective audit and feedback, formulary restriction, all these being practiced, the de-escalation of antimicrobials. I would like to mention here that even in the COVID times, we did not see more antimicrobial prescriptions happening in these hospitals because of the training on antimicrobial stewardship. So that, I think, it was one of the successes that we saw during COVID times with these hospitals.
Thank you very much. Thank you very much for your input, Dr. Kamini. Dr. Afrinish, nice to have you with us today. Can you, based on your experience, can you give us like an explanation of how do you manage data limitation when implementing evidence-based antimicrobial stewardship interventions?
Thank you, Rasha, and for first of all for organizing this important discussion. AMR surveillance remains one of the main pillar for the AMR mitigation measures, and I totally appreciate the efforts. And coming to your question, okay, how we can manage the data limitations when we are talking about the interventions. So AMS intervention is like huge. When we talk about the AMS data sets, it includes number of factors. It includes the clinical data, like the patient demographics, patient medication history, the outcome, diagnosis, number of things. Then it comes the laboratory data from the microbiology laboratory. What are the culture results? What are the antimicrobial susceptibility testing findings? Antimicrobial usage data from the patient bedside is again important. And hospital-acquired infections like HAI surveillance data is again a very important pillar for the AMS interventions. So data set is huge when we talk about the AMS interventions. And the limitations that I can think of is, first of all, is the data quality issues. Whatever the data from wherever sector we are generating, first question is that is the data is complete, all the variables are available, and if the variables are available, they are validated. And then there are many in data sets we see the problem of the missing data sets, and data inconsistencies are there. The other challenge that we see with the data is mainly the availability of the data issues. Like in many of the hospital settings, as Kamini was also mentioning, many of the data sets available in many resource limited settings, it is in the form of a manual records. So you don't have you have a limited access to the electronic health records, which is very, very essential for a very robust AMS implementation. And then you can have the lack of the laboratory data. Many of the laboratories, they don't have the capacity to go for the advanced testing, and eventually they won't be able to generate a good quality lab data. So the challenges are huge, and we talk about the quality issues and the availability issues. And when we talk about what can be the measures to overcome these data limitations, first thing first, whenever we try to kind of merge the AMR surveillance with the AMS, first thing is that we have to leverage on the existing data sources. Like many of the hospitals, they have already established HMIS or the LMIS. Whenever we try to intervene, always make use of already existing data sets. That helps the institute that they already have a very good system, intervene in that system and try to update or try to make it accordingly to your need. And it really helps many of the times. Then the other thing is that effort should be towards integrating the data sources, integrating the data from the multiple sources, where we can say there are electronic health records from the hospitals, then the laboratory systems, then we have a pharmacy whole database. That all needs to be understood and integrated to create a more comprehensive data set. And then we can think of using some chart reviews of the data reviews, And this data reviews always help to validate the findings and collect the additional data. And then over the time, what we have seen in your presentation, Rasha, as well, we have seen that there are some very good data collection tools which are available. And we should make use of these data tools as well. The last thing I would like to mention is that there are advanced technologies that we have seen in the chat box as well. There's a question about the AI thing. So machine learning algorithms are there. So use those machine learning techniques to predict the outcomes, to identify the patterns, and to optimize all the interventions that you are doing. And these data analytics tools can really help in many of the cases. Nowadays, I must suggest that that data limitation can be overcome by the use of the mobile applications. You can develop or utilize the mobile apps for data collection and for the provider notification or some kind of patient engagement as well. So these are some of the solutions to manage the data handling. You have to understand where is the data set and how that data is being generated. And then if you identify the right intervention at the right time, I must say that this is the right approach to go for a right solution.
Yes, yes, I agree with you. Thank you very much, Freenash. Back to Dr. Sashila. Can you provide us with example or what resource efficient AM antimicrobial stewardship strategies have you found it effective, and how adaptable are they? Dr. Sashila?
Sorry about that. I think I didn't unmute myself. Okay. So I think resource efficient AMS strategy should be tailored to specifically to healthcare settings based on available resources and identified gaps. As mentioned earlier, both Kamini and Afrinesh has highlighted that, different hospitals have different limitations with their resources. So I think the most important thing, before we, initiate anything, it's important to understand what are the gaps in our individual practices, and then have a proper implementation method. We have a lot of strategies, but also thinking about the implementation strategies are very important. So I think the first thing, when you want to understand the needs and your resources, I think, as we keep mentioning, surveillance is very important. What is our rates of hospital-acquired infection, what is the rates of our MDRO, and having good standardized definitions for this. And this can be done by doing a point prevalence survey or period prevalence survey using standardized definitions. And after identifying the gaps, you identify the gaps could be either you focus on a specific disease like pneumonia or UTI or even surgical antibiotic prophylaxis, or you can even, the gap could be, the problem could also be maybe the use of a broad spectrum antibiotic such as carbapenem or vancomycin or third generation cephalosporin. And I think doing these point prevalence surveys and audit and surveillances, we are also able to identify the problems in prescribing practices, such as giving the wrong antibiotic, wrong empiric antibiotics, or giving at the incorrect dose, lack of de-escalation or prolonged duration, and even giving it unnecessarily. So I also want to allude to the one of the toolkits that I find really, really useful to identify gaps and prioritize intervention in low resource limited setting is the WHO checklist of essential AMS core elements, which is available in the AMS program in healthcare facilities in low and middle income countries, a practical toolkit which was published in 2019. And this toolkit is really good because you're able to identify the core elements, whether you have it or not in your hospital, and you can prioritize what elements you want to put in your hospital. So some of the common interventions, I think that's already been mentioned, could be either prior authorization using pre-order forms, automatic stop orders, especially for surgical antibiotic prophylaxis, selective laboratory reporting. For example, in our hospital, we hide some of the antibiotics. For example, ciprofloxacin and carbapenem will not be, mentioned, and also audit and feedbacks and education. But one of the important things I want to emphasize on is the implementation process of AMS interventions. So, for an intervention to be successful and sustainable, I think we need good implementation process. And for that, what I have found really useful, important in our setting anyway, where the resource is limited, is to start small and scale up gradually based on on the resources that you have, as well as the urgency. For example, surgical antibiotic prophylaxis, you don't have to start it hospital-wide. You can start it with one surgical intervention, maybe cabbage, and then move on to others. So, starting with high impact areas like ICU would be the best thing. The other thing is when we come up with any intervention, I think for it to be successful, we must involve the primary team or the key stakeholders. Only then there will be buy-in and they will actually, follow the intervention. If not, no one is going to listen to you. And also for implementation, what I find really useful is the WHO multimodal strategy that has been advocated for infection prevention strategies, but I think it can also be used for AMS, and I use it for AMS as well, which is system change. The first one is system change, where you develop and adapt guidelines, checklists, and protocols to your setting. You involve key stakeholders, appoint champions. Then the second multimodal strategy is education and reminders, provide education to the key stakeholders using multiple methods such as role playing, as well as using digital tools for reminders such as WhatsApp messages and visual reminders, audit and feedback, and culture change. I think that's very important in this multimodal strategy. By making AMS maybe a hospital KPI, recognizing key stakeholders for their achievement and drive behavior change. So I think for any AMS strategy to be successful, it's important that we for it to be successful and sustainable, it's important that we tailor this intervention to hospital needs, starting with focused efforts and adapting a multimodal strategy that includes education, system change, and culture shift. So I think these are the things that we could do.
Thank you. Thank you very much, Dr. Sashila, for your comprehensive answer. I was delighted to make my systematic view, which I mentioned in my slides, which focus on investigating antimicrobial stewardship and strategies in the previous 20 years. All what you said is really, really one of the when I see the results based on 20 years, how antibiotic strategies used in developing countries and all among the globe, it was on the global level. I find these strategies really important, starting from a prospective audit and feedback, antimicrobial guideline, education, the presence of antibiogram or something like surveillance or infection prevention and the control data. All of this helpful to promote effective antibiotic stewardship, education, and the training. And the presence of the multidisciplinary team is really crucial. Thank you very much for your answer. Back to Dr. Afrinish. How have partnership with local and international organizations strengthened antimicrobial stewardship efforts?
Thank you, Rasha. So this is the question about the partnerships between for strengthening the AMS efforts. First thing first, whenever what are the key factors that you have to understand for going for a successful partnership? Whenever you go with some partnership, either it's a local organization or international, the thing is that there should be a very clear objectives that should be decided between the partners. Their role should be well communicated. And this helps eventually. This helps a lot that whenever the role is clear, the terms and conditions are clear, everyone contributes to its best.
Yes.
The other important element for the successful partnership is that there should be a good communication mechanism, a regular dialogue, regular collaboration or coordination between the two sectors. There should be mutual respect between the two parties so that you work very closely with each other and to achieve the goals. And now talking about the local coordination, local partnership for AMS, what is required? If there's a national stewardship program that has been established, it cannot go until and unless you have the institutional or the hospital committees engaged with you. So it's like if there's a national guidelines available, but the healthcare facilities should own it. The hospital should own it. They should understand the meaning and they can adapt the national strategies according to their need. Again, the other important local partners, they are always the public health departments. They help to go for that outbreak investigation, surveillance, or for the data sharing. Then the role of the allied sectors like the pharmacies, the nurses, nursing organizations, they should be well understood and well collaborated. Many of the times we miss the academic institutions, and they play a very, very important role in the case of implementation of the stewardship. They help us to understand all the social scientists, they help us to understand the clear meaning. They help us to in the data analysis. They can help to understand the research trends, and they can give you a platform for education and training, which is much needed.
Yes, yes, yes.
And when we talk about the international partnerships, there are many international organizations. First of all, WHO. So you have already mentioned about their different programs towards the AMS, the toolkit and the guidelines and the point prevalence surveys, HAI surveillance, they are available. And then CDC US, the European Center for Disease Control and Prevention, they have a very widespread European-wide AMS strategy program. The other organizations which are helping are the GARD-P and the ICARS. So there are, first of all, understand the whole dynamics. What are the local partners? What are the international partners? What are their objectives? How can we leverage on their activities? And how can we make use of their expertise in the best way? And what we can see is that of all this connection and coordination, what we achieve, we can make, there can be availability of the standardized AMS tools and practices. Already available data is there. Like WHO has published number of the good data sets. We can make use of that harmonized guidelines and protocols and adapt to our data according to our need. And we can enhance our surveillance. Again, knowledge sharing, the best practices, they can be well understood. They can be more education and training through these local and public-private partnerships. And the other good thing is that we should learn from the other countries. A few days back, we were discussing with each other about the policy development. Very important thing that resource limited setting, they have common challenges. Kamini is here, Sashila is here. They can understand the problems within our countries. If one country has a good policy towards some regulatory framework, this always helps the other country to understand, to implement, and make use of that policy as well. So these are some of the things that I think of suggesting to you. And Rasha, I stop over here for a minute. I am seeing a question in the chat box, and the question is related to that. How can we explore the potential of the public-private partnership in addressing the AMR? So this is the thing that you have to understand what is the strength of the public sectors, what is the strength of the private sectors, and the major role that we can make use of is the resource mobilization. Either it is the funding, either it is the human resource mobilization, either it is some tools, educational material, any data management softwares. So this is kind of, we can make use of each other opportunities.
Yes, yes.
So I'll stop over here.
Yeah, thank you very much. Another question, Dr. Afi, lost a question with us today. How digital tools improve AMR surveillance and the antimicrobial stewardship outcome?
Yeah, Rasha, you have already also mentioned some of the tips regarding the data tools in your presentation as well. I was looking at it. And for the AMR surveillance, the most important thing is these digital data tools, they speed up your work.
Yes.
You have something in front of you and you can use some of the tips and tricks and you can analyze these data sets. So electronic laboratory reporting, hospital management systems, if they're established within the system, they always help in the AMR surveillance. And then if you have these automated interactive dashboards, they help for the clinicians, for the pharmacists who have less knowledge towards the pathogen names and or other AFST results, that if the dashboard is interactive, they can make use of this opportunity. Then we have already discussed about that machine learning approaches and the mobile applications. The best thing for the AMS, I have a discussion with some of the colleagues in Pakistan related to their AMS programs. And they have a very, very robust clinical decision support system, CDSS systems. And this CDSS system is helping them a lot. Like they have the data sets from the laboratory, from the clinicians, from the pharmacists. And these support systems, they are providing the real-time antibiotic recommendations And this is a really bringing the change to that hospital setup. That is a cardiac hospital, and I can see a good change over there. And I have seen very good antibiotic stewardship softwares, and they which track the antibiotic use, and they can help us to optimize our treatments and monitor the outcomes.
Yeah.
So that's some of the regarding the data tools. Other things are telemedicine. Very recently, we have seen that digitally, when it was the time of the COVID, there's a huge use of the telemedicine. There are remote consultations. There are remote guidance from the healthcare professionals. So that was again a helpful approach.
Yes, I agree with you. Thank you very much, Dr. Afrinish, for all of these impressive recommendations and advices regarding the partnership and digital tools. Back to our last question with Dr. Sashila. What recommendation would you give for strengthen antimicrobial stewardship in resource-limited countries?
Yeah, I think we have a lot of challenges, right? So I think to strengthen AMS in a resource-limited setting requires a combination of strategic planning, resource allocation, and collaboration. And the thing is, I think we need to understand we can't do everything. We really need to prioritize, and that's why the checklist is very important. Always starting small and doing it well. Someone once told me you won't see the benefit of AMS immediately. You only see it after 5 years, 6 years. So don't be disheartened when you start off, but start somewhere and start small. So I think the first thing, some of the key areas is one is integration of AMS into your national or hospital AMR action plan. So you make sure your hospital prioritizes AMR as an action plan, and make sure there's some funding given for essential activities of AMR. Not everything, but at least on surveillance or maybe one AMS program at a time. So and also try to look at external grants if you're from a university or even pharma hospital partnerships. Now you can speak to your organization, speak with your organization. The other thing is mandating a multidisciplinary AMS team is there in your hospital. So if you have a national, in Malaysia, it's a MSQH, mandating that you have an AMS program in your hospital and you have an AMS, dedicated AMS team, even of a small AMS team is fine, and their roles and their responsibilities are clearly defined. The other thing I find very useful is having a specific guideline that you can adapt from international or nationally, but context specific for your hospital. So have a protocol which is specific for your hospital and speak to the key stakeholders. For example, if you're having a UTI guideline, call your nephrologist or your gynecologist or whoever who primarily or your outpatient doctors into it. Of course, education and training should be part of the hospital KPI. So for example, in Malaysia, part of the MSQH KPI is 100% of all new healthcare workers must be trained in AMR. So it can be IPC and AMS, as well as 80% of old staff must be trained as part of our MSQH KPI. And as I mentioned earlier, making sure you have used a multi-model strategy in whatever intervention you put in. So, system change, audit and feedback, education, communication is very important, and surveillance, as well as culture change. And diagnostics, yeah. So these are some of the things, and of course, partnership and network has already been mentioned. So I think these are some of the things that we can do in resource-limited setting to improve our AMS strategies and interventions.
Thank you very much. Thank you very much, Dr. Sashila. I'm delighted to have you with us today. The last question for Dr. Kamini: what antimicrobial stewardship materials or toolkit do you find it most valuable, or how can they be effectively in the resource-limited setting?
Thank you. So the previous speakers have already talked about the guidance and the resource materials which is available. So I would reiterate the same. There are guidance documents available from WHO. There are guidance documents available from CDC. But what I would like to emphasize here is that those guidance documents must be customized as per our local needs. As Afrinish pointed out, Sashila also pointed out, we have resource limited settings, and many a times, it is not not possible to implement the guidance documents the way they are presented because of the lack of the trained manpower, absence of the digital tools that are sometimes needed. So that's why every country must have their own guidance documents which are customized to their own needs and their own healthcare systems. And that we found very helpful in India. As I mentioned, that we have an antimicrobial stewardship guideline which is available on the ICMR website, and that actually provides guidance on how AMS can be implemented in hospitals from the scratch. That gives guidance on the tertiary care hospitals as well as the secondary care hospitals and the small labs, how they can, small hospitals, how can they make small beginnings. What we emphasize is that every hospital must have its own antibiogram. It is nice to have a national antibiotic policy, but it is more useful to have a hospital specific antibiotic policy. And in the absence of local antibiograms, you cannot have a local antibiotic policy, and that's what we always emphasize on. The other very important point is the resources for antimicrobial stewardship. While we talk of partnerships, we talk of international partnerships, but I think the local resources from your own hospital by your own government must be allocated for this activity. Only then it can be sustainable. Otherwise, when we provide or when this is funded by an external donor or any international funding agency, once the funding dries up, it is very difficult to sustain this activity. So this is another very, very important point to be borne in mind when we initiate the antimicrobial stewardship programs. Infection prevention control programs, strengthening of those programs, again customized as per our own requirements of our hospitals, that must be emphasized and should be done in parallel to the antimicrobial stewardship activities. So all these actions, when we take collectively, I think one of the speakers pointed out that it is not possible to see the impact early. It takes at least 4 to 5 years for us to really see the impact of these initiatives. The last point I would like to make here is the importance of multimodal approaches, which the previous speakers have also highlighted. Multidisciplinary teams having the digital tools and the resources. These are, I would say, this is the foundation of a good antimicrobial stewardship program.
Thank you very much, Dr. Kamini. Thank you all the panel discussion speakers to be with us today in this panel discussion for this important webinar for the World Antibiotic Awareness. We started from the bacteria or the culture results that resistant to all antibiotics, and we end up with possible solution for antimicrobial stewardship effective practices to try to confront or fight the antimicrobial resistance in the resource limited countries and among the globe. Thank you very much for joining us.
Thank you, everyone. Have a good day.
Thank you.
Thank you.